that we talk about will involve tuberculosis. Now, tuberculosis is an important disease that you should be familiar with because you will treat in clinical settings a significant amount of individuals who either have active tuberculosis or individuals who certainly have been exposed to tuberculosis and are taking antibiotic therapy to try to prevent a occurrence of the disease. Now, back in the day, tuberculosis was very much controlled. Individual had tuberculosis, you got tuberculosis, you got to go to the sanatorium, and they'd take you to a hospital and they would treat you until you were not infectious anymore, and then you got released to go back home. You can't do that today. Public health organizations are limited in their ability to incarcerate an individual and force them to take treatment unless they are willing. It can be done, but it's a very complicated process, and it's not done because it's a threat to you, the public. It's done because you judge the person a threat to themselves. So if a person doesn't take tuberculosis medicine, whether he sits here in a room with you and coughs and everybody gets tuberculosis, that's not the issue. The issue is, and where you have to require the person to receive treatment is, you have a disease that can kill you, and because you're refusing to get treatment, you're saying that you want to kill yourself, and so I have to protect you, and so I will put you into custody and I'll make sure that you get treatment because I don't want you to hurt yourself. And so that's how the laws are set up now. And unfortunately, because of that, you see a rapid spread of tuberculosis now. Back in the early 1970s, 60s, tuberculosis had almost been eradicated from the United States. But through the 70s and latter 60s and 70s, a lot of those laws that enabled healthcare providers and law enforcement agencies to be able to mandate treatment of individuals has dramatically changed. You're already familiar with how you diagnose tuberculosis using the acid-fast or the Ziehl-Neelsen staining technique. Tuberculosis usually is acquired by inhaling, but remember there is the gastrointestinal presentation of tuberculosis as well. Macrophages, especially macrophages in the alveoli, can phagocytize by, or can be attacked. I'm sorry, said that wrong. The macrophages in the alveoli can attack the tuberculosis and destroy it, but in some cases when it does not, the organism is walled off, and you'll see the development of these nodules inside the lungs, tuberculin nodules, that have actually active bacteria inside of them. The body itself will attempt to wall it off, and so it may lie dormantly in that walled off portion of the lungs for many, many years, typically at the apical portion of the lungs. And then when the immune system of the individual becomes compromised, you'll see this release of tuberculin organisms. For the skin test, you look for a skin reaction. You can give an intradermal or subdermal injection of tuberculin, which is a little dead shell of the bacteria injected under your skin. And if you get a wheal or a raised area on your arm, usually you put it on the left arm. It doesn't work for people who are left-handed, but you don't shake hands with tuberculosis. So don't put it on the right hand, put it on the left side. And so that's how we remember what side. Because sometimes you use a control. Some people will react to whatever the agent is you give. You give tuberculosis, they're going to react. You inject sterile water, they're going to react. So what you do is you put tuberculin skin test, and then you also put a control. Usually you use a little fungus like Candida. You use a Candida control because you want to make sure the person's just not reacting to the needle being put under the skin. You usually wait 3 days, and the person comes back, they have this wheal or this indurated area, then you know that they have been exposed to tuberculosis. Now all the skin test tells you is that the person has been exposed to tuberculosis in the past and has antibodies. Doesn't tell you if the person has active disease. Now if the person's coughing and the person's got respiratory problems and pulmonary congestion, then it's a good guess the person may be infected by tuberculosis. But the person may be perfectly healthy. Healthcare workers, for example, go in and get skin tests done at least once a year. Not sick, but were exposed to a patient with tuberculosis and have developed antibodies. Doesn't mean that they're going to even get tuberculosis. Just means they've been exposed to it. But when someone seroconverts, in other words, didn't have I had a negative tuberculin skin test last year, I went back this year, and now I have a positive tuberculin skin test. Okay, those individuals usually will go then for a chest x-ray to make sure there's no finding on the chest x-ray of pneumonia, and then the individuals will probably receive what we call prophylactic therapy. Doesn't mean that we know for sure that they have the disease, but because they were negative before, then we should treat them with one agent, one drug, for at least 3 months, prophylactic therapy. Now, individuals that I got exposed to somebody with tuberculosis 2 weeks ago, and I'm getting a skin test, I'm negative, I check it again 2 weeks from now, it's still negative. 2 months from now, positive, then again I was exposed to a person with tuberculosis, and that would be a candidate for prophylactic therapy. Many individuals that live in the same household with someone with tuberculosis will receive prophylactic therapy. Then the individuals that are infected with tuberculosis, those individuals usually have to go on 2, 3, sometimes even 4 drugs to treat the infection. Tuberculosis is not easy to treat. There are drug-resistant forms of tuberculosis that have developed over the years as well, and so a little more difficult to treat. You have to be a little more aggressive, so at least a 3-drug regimen. And we'll talk about drugs if we have time next week. There are different types of agents that can be used to fight these types of these bacterial infections. Tuberculosis, different forms. You can have the cavernous diseases where these huge bullae will form. You can have a miliary disease, which are multiple little small lesions that can not only infect the lung but can be spread to different areas of the body as well. Worst case of tuberculosis that I have ever seen was at Tampa General. Guy traveled from overseas, I can't remember where, but he had these huge vegetative lesions, these big vegetative lesions of tuberculosis in his heart. And all over his skin were these big, thick, nodulated areas, and the biopsy in subsequent culture revealed that that was tuberculosis as well. It was suspected that it was in his GI tract as well, but as I know of at the time, that was the only reported case of tuberculosis in the heart. But the reason why they say tuberculosis, and you may hear this statement stated that tuberculosis has many faces, because it can infect almost any organ system, primarily by transmitted lungs and GI tract. But once it's in the system, it can spread to other organs as well. So just keep that in mind. Drugs such as streptomycin, rifampin, INH, and ethambutol are basically used to treat the disease. Talked about the skin test already. You're familiar with that picture already, those acid-fast bacilli of Mycobacterium tuberculosis, transmitted from human to human, not transmitted from human to human or organisms such as Mycobacterium bovis. And then there's also a Mycobacterium avium intracellular complex that infects individuals with HIV disease, so it's more of an opportunistic type of an infection. This is just basically how those granulomas can form. Small tuberculin cells start to grow and multiply, then become walled off in a tissue layer. They can be walled off and lie dormantly for years at a time, and then will re-exacerbate if circumstances are right. There are vaccines out there, and it's important to recognize that. Healthcare workers from Europe, England, are vaccinated for tuberculosis. From Australia, New Zealand, places like that, they get active vaccinations for tuberculosis. And so if that individual comes to your setting to work, they don't need to get a skin test because their skin test will be positive. They have already received a vaccination for tuberculosis, and because they've received the vaccination for tuberculosis, they have developed antibodies to tuberculosis. And so important to keep that in consideration when you're doing, say, an employee physical on someone from away. This is an example of what a tuberculin skin test would look like. Prominent lesion there on the arm. Mycobacterium bovis is the cause of bovine tuberculosis, usually spread by unpasteurized milk. There's that unpasteurized milk again. Vaccine, BCG, live attenuated organism. Tuberculosis in the body combats a cell-mediated immunity and is frequent complication of AIDS. anyone who is immunocompromised, AIDS patients, diabetic patients, patients who have been receiving chemotherapy, anything that suppresses the immune system, chronic corticosteroid use, anything that suppresses the immune system makes that person a little more vulnerable to picking up tuberculosis. Just the distribution of the disease. Now, bacterial pneumonias, again, lower respiratory system. Bacterial pneumonia is applied to many pulmonary infections. Pneumococcal pneumonia, which comes from strep pneumoniae, is an organism that can get in deep tissue of the lungs and lead to significant infections. These organisms can be cultured out on a plate, an opticon plate, which I'll show you in just a little bit, which demonstrates a clear zone and helps to identify the organism. A vaccine is available as well. The pneumococcal pneumonia vaccine is also available, usually administered at the same time as the flu shot once a year. Penicillin is a drug of choice in treating most treating most pneumonias. Now recognize many organisms now are drug resistant, polydrug resistant, and will be resistant to tuberculosis. But if you don't see this drug sensitivity, or certainly if the infection or the pneumonia is picked up from outside the hospital, infections typically are caused by organisms that are sensitive to almost all the antibodies. You usually can start them off with a small dose of you can usually start the person off with a very small dose of penicillin because the organism is not resistant. But if the person picks up the infection while they're in the hospital, you can bet your shoes that this individual is probably not going to be, or the organism is not going to be sensitive to antibiotic therapy. And in those cases, usually more aggressive therapy has to be utilized. So clinically, similar to pneumonia, strep pneumonia, and then Gram-Stain offers a differentiation between that and strep organisms. Strep pneumonia, gram-positive encapsulated diplococci, diagnosed by culturing bacteria. Penicillin is a drug of choice. This is what I was telling you about. The opticon disc can be dropped onto a plate. You get this field of organisms, whatever the bacteria is. You see it's just inundated and filled that plate completely up. Can you appreciate that in the back? Can you see that picture? Yeah. And then you drop a disc, an antibiotic disc on the plate, and you see this zone of clearing, which means the organism is very sensitive to the antibiotic that's being released by this antibiotic. And so now you know the drug sensitivity of this organism. You know, if this is cephalosporin, if this is gentamicin, tobramycin, and wow, look how well we did when we utilized the penicillin. So you drop the tablets, and they have a bunch of these different types of tablets that they can drop on a plate, and you look for the zone of clearing. Gram-negative coccobacillus, we see this in alcoholics, people with poor nutrition, cancer patients, diabetic patients, second generation